Okay, I hope everybody is sufficiently restored, and I know that a few of you even managed to try some of Professor Clark's ketones. Right about now, you should be entering ketosis and feeling extra sharp. So I'd love you to use your newly transformed neurons to ask our lovely panel some really exciting questions. Who would like to start first? Oh, come on, don't be shy. Okay, the gentleman at the top.
Or shout.
Yes, here. Oh, that's not going to work.
We're going to have to answer all the questions. You're the only one with a microphone.
Hello. You've talked about diet and all that kind of thing. I wonder as well if you could address the question of overmedication, which is a big problem in Western medicine especially. And it seems like, well, from a GP perspective, because of the limited time, one of the objectives is what kind of medicine can I put this guy on? And also I think you end up, if you have a complex, whatever kind of issues, you can end up on 10 different medicines. So also there's often warnings on some of these supplements that say, please seek medical advice before taking them, which you have to respect, but at the same time, sometimes the medical advice is under no circumstances take any of these things, so.
Okay, should I answer that first? I didn't know everyone else would chip in. So as a GP, we do really worry about polypharmacy, rightly so. We do have audits within our own practice and on the NHS within general practice as a whole. We check, particularly, as you know, people who have, say, 10 or more medications. We do check in. We do, on an annual basis, a medication review within the confines of time. There is, of course, that risk of interactions, etc. And it's very difficult. If you think about clinical trials, let's take heart attack, for instance. You'll be put on an ACE inhibitor, beta blocker, statin, etc., etc. I don't think, to my knowledge, there are any trials to show all of those in combination to say, does it really, really help for you as the individual? However, we know that each bit of it seems to help. The question then becomes, the latter bit it was about in terms of supplements. And that's a really difficult one because to a certain degree, when you buy any supplement, it says, well, if in doubt, call your GP or doctor. We don't know everything. And to a certain degree, dosage is very difficult because there's always agendas when you say, well, I asked the question earlier, how much do you use for the delta G, for instance? Is more better? And are there complications with it? Okay, you can sometimes stack on the thing in terms of additive effect, synergistic in the positive side. You can understand in the other aspect, with additive, it may actually cause detrimental effects. So that's a very difficult one to then say, okay, well, how do we decide what next? And I guess from the patient's perspective, the difficulty, of course, is that, okay, you're on one medication, you have another condition, you've got another symptom, you then take another medication, and then to counteract the side effect, you then take yet another medication. And it becomes a sort of a snowballing effect. And my baseline is, and I've told some of you early on, I just say, if I can, I'd rather not give any medications. That's my baseline. But if you need a helping hand, you need a helping hand, end of. And again, you still have to then put faith in science and medicine to say, okay, well, here's the evidence. Okay, evidence slightly loosely, depends on how you define evidence, scientific, double-blinded, that sort of things. But again, it is, to a certain degree, you can also stack on to what we talked about, the responsible patient, the lifestyle stuff that I've talked with most of my colleagues, to then say, okay, well, can I optimize my blood pressure? If I reduce it, can I come off, or at least half the blood pressure medication? You may be on amlodipine, ramipril, or whatever. It might be the statins, your cholesterol level is dropping down. You've hack's the wrong word, but you've optimized things so that you now know that when you go to your GP, actually your cholesterol, your LDL has come down, or your total cholesterol to HDL ratio is actually come down as well. You can then take and have that discussion, be smart about it, ask your GP, for instance, and say, well, actually, what are my results? Can we reduce it? And then have that discussion. It may well be that actually, well, if we take about statin, I don't want to open a whole can of worms. I mean, statin is a very difficult one. If we take it from the NICE guidelines, usually my conversations that I have with all of you here is if, for instance, we have a statistical tool called the Q-risk-2 score. That enables us to determine, over the next 10 years, what is my risk of having a cardiovascular event, be it a stroke or a heart attack. And usually, a value of 20 and above, we tend to say, actually, the medical advice is to start a statin. And I know Michael Stein earlier talked about numbers needed to treat with the statin. Well, there's always a flip side, the numbers needed to harm. And it's a very difficult one because we then say, okay, if you've got a Q-risk-2 score between 10 and 20, the medical advice is to have that shared discussion with the patient to say, actually, is it worth being on that statin? More recently, however, actually, those guidelines have actually shifted even further. We say 5% to 20%, we should be having that conversation or having a statin. And at our practice, we're sort of saying, well, does that mean that we all condemn you guys to all be on statins? Not too sure. Yeah? And then all these things, this is just taking statin. You've got all the polypharmacy, you've got all the other medications. It's very, very difficult. So again, you need to take responsibility of what you can, look up the stuff you want. Supplement, there's a good website, I think, called examine.com. Yeah, examine.com, which is quite useful. Again, it always has a disclaimer, when in doubt, see your GP. Well, I can't give you the answers. But again, make smart choices, figure out what works. Okay.
Just a few common supplements that people get into trouble with. Omega-3, for example, people can take vast quantities of fish oil recommended by the internet, and that can affect how thin your blood is if you're on anticoagulants or aspirin, for example. So that's one thing. And then magnesium citrate, people often overdo magnesium citrate and wonder why they've got stomachache and diarrhea. Same with vitamin C, it can have a gut stimulatory effect and people notice that. But there's other things like St. John's wort. This is the few things I'm going to mention that people take for depression. If you're already on a SSRI like Prozac or sertraline or citalopram, then you can get serotonin syndrome. So things like St. John's wort, 5-HTP, tryptophan, they're often found in sleep remedies. And if you're on any psychotropic medication, then taking these sleep remedies is not a good idea.
I'm the patient who is completely baffled by what supplements I should be taking and what I shouldn't, and how to evaluate them. I reckon, I was just doing a count, that I'm taking 12 medications and supplements per day, different ones. The medications are for the heart condition, of course, which is a lifetime, I'm told by my doctors. I've got to go on taking them. And the supplements are built up, and as a result of today, I've got 2 more supplements to take home with me.
We're having a discussion later, by the way.
Yeah.
What I would like from my doctor, who's sitting 2 seats to my left, is what I used to give my students as a teacher, the distinction between what you must know, what you should know, and what you could know in the subject we're studying. And what I want is a list of the supplements I must take, the ones I should take in an ideal world, and the ones I could take but are dispensable. That would be really helpful to the patient. That's my contribution.
Good. Did you have another comment, Dennis?
Just want to add something to this discussion. There is hope on the horizon. There is an experiment that has been going on for a very long time on the combinations of very many of the chemicals and products that you've learnt about in this day's symposium. It's been going on, in fact, for something like 400 million years because plants have progressively, through evolving to be eaten by us, have worked out, serendipitously, of course, but also with all the purpose they've got. Well, let's get into that. They have worked out the combinations that are effective and safe. We ought to learn from that. And it's time we did. We haven't, because most of my scientific colleagues think that what I've just said is absolute nonsense.
Very good. Another question, please. Let's see, all the way in the back. Can we get a microphone to the lady in the back with a striped shirt, please?
Thank you. My question is for Dr. Thompson. Are there any long-term side effects of taking resveratrol? Because I believe there are studies that show that it's highly estrogenic, and there's some concerns about possibly increasing the risk of breast cancer and cancers that are known to be that are known to grow from like estrogen. The other question I had was, is niacinamide or niacin comparable to NR or NMN? I know some people say it's the poor man's NMN. And then, long term, are there concerns about methylation when taking things like NMN or NR? And then I have a question for Dr. Olivia. You mentioned something about about liver health. Do you have any strategies for, improving liver health and making sure that these hormones get metabolized properly by the liver? Because we all know the liver is the one of the major powerhouses for metabolism, and if your liver is not happy, you end up having poorly metabolized hormones such as estrogen or progesterone. And I think
Thank you for the questions. There's a lot to unpack there. Tam, did you want to take the first ones?
Yeah, I'll do my best. Resveratrol, I'm not aware of all the studies that you've mentioned, but there's David Sinclair's lab has tested very high doses of resveratrol in mice, and some of the concerns that you mentioned have been raised, but in practice, we don't ever recommend macro doses of things, like big doses of things like resveratrol, to be taken consistently for a long period of time. Obviously, the estrogen effects you can monitor by taking either something like the Dutch test, which looks at the metabolites of estrogen, or just by measuring an estradiol in your blood. But again, I wouldn't recommend taking isolated high doses of specific supplements like resveratrol anyway. I do recommend resveratrol occasionally, but I think with many supplements, it's good to pulse it. It's quite serotonergic as well. It supports serotonin, the happy hormone, resveratrol. But yeah, that would be my main takeaway with resveratrol. If you have any breast cancer risk, then that needs to be looked at independently. But again, any high doses of anything, I think, can cause problems. The next question, just remind me, related to... Oh, yeah. This is quite a contentious issue. When we talked about NAD, which is this universal energy molecule in the body that declines with stress, infection, travel, and age. We know that people age better. Well, there's a correlation with aging well and higher NAD levels, so that we know that taking things like, you've mentioned two things, NMN and NR and niacinamide, all are forms of a B vitamin. Essentially, NMN actually gets converted to NR plus something else in the gut and actually gets absorbed as NR. For one of those reasons, I don't take NMN because it's more expensive. I do take NR from time to time, although I don't really know if it's doing any good. There's a new supplement on the market, I have no commercial relationship with them, called, which is NAD3, which are a combination of things which I think the body works better with. If you give it multiple cofactors, it's more likely to support certain pathways than if you just macrodose with one thing. So if you're looking at NAD generally and you want to support NAD levels, then potentially NR and related cofactors can help. But again, you have to look at the things that you can change in your diet first, right? Like better nutrient-dense food intake, or the light, quality sleep, all of that, stress management. So those would be the main things. I hope that helps.
And then Dr. Olivia, liver health?
So with regards to the liver, one of the things that we have seen is an explosion of fatty liver or metabolic liver issues in younger and younger people. We absolutely look at the diet in this case because we know that fructose load can actually lead to fatty liver. And so when we're talking about fructose load, we're talking about juices, concentrates, and sodas. In trying to clear the fat from the liver, we are looking at phosphatidylcholine, so quite high doses, obviously to be discussed with your doctor. But I've had a patient go from like a stage 3 back down to no fatty liver in 10 months because of a combination of milk thistle, so silymarin, as well as phosphatidylcholine, and of course, sauna, which we both love, to induce autophagy, as well as spermidine, actually, which is a fantastic inducer of autophagy too. And autophagy, as someone mentioned before, is like a housekeeping signal. Mm-hmm.
And Dr. Sear, you had a comment
I'd
too.
like to make a comment that relates to this question and the previous question about polypharmacy. And it's the interaction between the supplements, the plant compounds, and also the medications. Especially if someone has the multi-morbidities, you're taking many different medications. And one thing that Tasman mentioned earlier on in her talk was xenohormetics. Now, what does that mean? It means that the cells, our cells and tissues and so on, are getting a little bit stressed by the compounds that we think are being beneficial to us. And so we need to be careful, what are the medications doing to the cells at the same time as the supplements? So we don't know the answer, but we have to bear that in mind. Secondly, the question about estrogens, for example. Dietary plant compounds are estrogenic. They can activate estrogen pathways. But we need to consider what are the metabolites of the plant compounds. The microbiome converts many things that we eat into metabolites. And depending on where you are, who you are, and so on, very personalized microbiome can also have consequences on the metabolites. And we need to do more research in those metabolites that are in our blood, how they impact on many different cellular signaling pathways, including the estrogen pathway.
Okay, next question. Up at the top, in the white shirt, please.
Awesome, thank you. Just want to do a rapid fire round. If there's, for everyone on the panel, if there's one main takeaway for everyone in this room, what would it be? So either behavior to avoid, certain behavior change, supplement, or something not necessarily actionable as well. What would that be? Thank you.
Can I start so that everyone else?
Yes.
He wants
One takeaway.
Yeah, one takeaway.
One takeaway. What's the one?
One
Oh,
takeaway
one
from today.
takeaway
Yeah.
from each of us.
Top tip.
Top tip. Why don't we start with Kieran? Let's start with Kieran. It's a top tip. Yeah.
Top tip. I'm afraid my top tip would be to avoid hypertension from a very young age. Just don't get hypertension.
My top tip would be happy.
Exercise and sauna.
My top tip would be hold a conference like this once a year.
I think it's the effect on the physiology of mindset. And I have absolutely seen very complex conditions reverse by pushing that particular lever in particular ways.
I would have the two words from our conversation, purpose and hope. But that can be unpacked if you've got another 2 hours.
Well, mine is just a sentence. This is the return of proper integrative physiology after about 50 years of absence.
Very good. Very good. Okay. Now, I know we had a question from the front, so.
Hello. One of the slides that was up showed a study that men who spend a lot of time with women in their formative years live 15 years longer. 15 years is a lot of years. Any idea what the mechanism is, or any more about that study? Yeah.
So very quickly, the adverse childhood events right? It was a study that actually showed that the more adverse events in childhood that someone had, the more they were predisposed to issues later on in life, including depression and mortality, morbidity, and so on and so forth. And you know, I don't want to get into any political debates here, but there is something to be said about the nurturing of a mother during those formative years, which I think would be very protective.
Something to do with our boarding schools here in England.
I think you were saying a little bit about like polyamory, essentially. Like, am I getting your question right? I didn't hear that. I thought you said the more time men spend with women in earlier years makes them. Okay, no, there is something about in the research about men and polyamory. It doesn't go the same way for women, but I feel it's to do with like ego and status and testosterone, but I'm not aware of the actual detail of the research. But there is something in the sort of lobster theory of being top of the pile, like with the in the male structural system. But yeah, I don't know the exact paper.
Okay, next question.
Ask Jack, because Jack probably knows.
Oh, Jack, okay.
Can I answer?
Christopher will answer.
Okay, yes.
This is something I feel I know about. Oh, right. Thank you so much. I've just been writing poetry, actually, but I do my teaching through verse. And I've been writing about parenthood and how to be a good parent. And two things are clear to me. Perhaps they add up to three. The first is what works best is to have two parents of different sexes. That's obviously a controversial point to begin with. You need a father and a mother. In the early years, there's very clear research. The person who I rely on is called Bowlby, who was a psychologist in my youth, whose work I read and was moved by the enormous importance of the mother in those early years. And we've created a culture where women understandably want to have it all in that phrase, and that means going back to full-time work before their baby is ready for it. That is a great crisis of development in our culture, which we find it very difficult to talk about, let alone face up to. But fathers are equally important for the slightly later stage of schooling. There's clear research evidence that children in homes without fathers, and there are all too many of them today, don't perform as well at school, don't get a place at a university if that's what they want when they grow up, and are at a disadvantage throughout their lives. In other words, the old model was right. For our species, you need two parents who can commit themselves to the job right the way through and give the child support right the way through. And good childcare is not an adequate substitute. I do realize an old man saying something like this is liable to get thrown out of the conference, but it's nearly over, so it won't matter.
well, actually.
Okay, good.
Actually, I just wanted to say that the old model was actually the village, not necessarily two people stuck in a home, right? It was a village, and that's the old model, and I think that's what we should be aspiring back to.
More community. Jack, go on. Can you shout? Okay. Sam.
I've got a semi-serious question and a semi-not-so-serious question. The first one is actually related to biomarkers. I think this is a very important thing, diagnostics. I'd like you guys to give me one sentence each on what are the diagnostic criteria for deleterious aging right now today. And the second question is to Dennis on the subject of life and longevity. Dr. Internet told me the other day that I should be on Viagra. Your thoughts?
I'll answer the Viagra one.
One sentence.
Okay, I'll answer the Viagra one. Right, Viagra is an interesting substance which has been flagged up in the anti-aging circles. As you all know, it's an erectile dysfunction drug used to enhance sexual intercourse, although there is increasing evidence that it can be an anti-inflammatory to the vascular endothelium, being the blood vessels that run throughout our body. So the data is not there, but a lot of people in this longevity biohacking space are microdosing sildenafil, which is one of the forms of Viagra, with the view of reducing vascular inflammation. So if you have less inflammation in your arteries and your blood vessels and your small vessels, the likelihood of your cholesterol coming in and sticking to that blood vessel, creating plaque, creating things that eventually evolve to become cardiovascular disease, stroke, may be reduced. But again, this is all information that is out there. But the side effect would be that you'd have a good active sex life, which can be only good for you. Yes, but it does increase blood pressure, so there has to be caveats.
That's the better microphone. Yes. You don't need Viagra. More seriously, there is an article on Aeon, which I wrote about a year or so ago, simply called Slow Sex, Long Life. It says everything.
And a word about biomarkers. I can't give that. But I will say that in my practice, I judiciously test, because I think that there is, just because we can doesn't mean that we should. And there is a lot of over-testing that I have seen in not so much the conventional world, but certainly outside of it. You know, the fact that we can test your microbiome of every bits and, you know, of your body, and, you know, every blood test and every hair test, and it's, I think that we're doing a disservice to patients when we over-test them. Generally speaking, I test if I'm at a crossroad or if I'm up against a brick wall and it's going to change my management.
I think the value is in longitudinal data. What do I mean by that? It's looking at trends, and Samantha mentioned this to me in the break, and I think if a key takeaway, if you can afford it, there's lots of very affordable blood testing companies available in the UK now, like Medichecks, Thriver, Inside Tracker, which you can upload your blood tests even from your GP. If you get to see trends, like what you don't want is your blood sugar level, your fasting blood sugar level, slowly raising over time and then sitting around at a 7. So I think blood glucose management is super important. If you can afford a continuous glucose monitor, there's things that you can stick on the back of your arm for 2 weeks. I think getting that kind of information is super important, because there's a lot in glucose measurements, blood sugar, that is a proxy for other things in your life, like stress, like sleep deprivation. So I think knowing those kind of markers would be super important.
Like erectile dysfunction.
From the patient's point of view, it seems to me, I want to go back to the point I made quite briefly, that those developments of degenerative diseases in our old age, cancer and heart disease and dementia, to name but 3, Parkinson's disease 4. When you begin to get symptoms of any of these conditions of longevity, which we sort of take for granted as almost natural, and we say bad luck or something, you should re-diagnose them as a wake-up call. Whatever they are, as the patient, you should say, this is a gift from heaven. It's a wake-up call for me. I am doing something or many things wrong. I need to reorganize my life. And there is evidence, I think, that if you approach these conditions early with a recognition that you need to change your lifestyle and mindset, you can really make a difference. Now, that's slightly different from the doctor looking at biomarkers. This is the patient looking at things that could be a useful, positive wake-up call. And that's my philosophy.
Can I address the biomarker question? And to reiterate Kieran's point earlier on, blood pressure, hypertension, crucial, good evidence, basic, it's measured across the population. And it's actually linked to Viagra. It's developed as an antihypertensive originally, as a, a phosphodiesterase inhibitor. But we don't know what else it does. There are many clinical trials out there, other beneficial effects. I'm often asked the question, what's a biomarker? You asked about disease side of aging. What's a biomarker of wellness? So I think that's also a very important point. What should we measure? Is it a blood biomarker? Is it blood pressure? Is it heart rate? Is it contentment? Is it joy? If there is such a measure.
They found, haven't they, that subjective, if you ask someone objectively how well you feel, it's very well correlated with measurements of wellness in the blood, like lower blood sugar, etc. So how well you feel and blood pressure is a good indicator of how well you actually are.
Yeah, I think I would echo that. From a GP's perspective, as we know, we don't really test much for aging. There isn't a marker per se. And of course, in the integrative, the functional side of things, there are lots of things that you can stack on. Biohackers will go to the nth degree to find things and then decide what they want to do in terms of supplementation, do other things. I think from my take is, of course, from an NHS perspective, there's limitations, and that's how it is. But I do think that it boils down to a certain degree, and I said the key word for me is happiness. We can go and look for things to the nth degree, and we can carry on doing that. But that exercise in itself, for lack of a better word, is, I think, to a certain degree, can be quite detrimental. And we're in the state here where we're all looking for smart aging. And I think we're doing that. And I think rather than biomarkers per se, yes, it may well be that medical technology advances, AI will help, machine learning, AI reasoning, all these things will help augment and help the clinicians to be able to then decipher, okay, what can we do to reverse the hallmarks of aging? That will come in play. But I do generally believe that in terms of the individual, we just want to make sure that we look into ourselves and try to find happiness. And I think that's the bigger thing that resonates for me. And I hope that resonates to my patients.
Very good. Now we have time for one last question. I'm going to ask Olivia to choose someone. Yes, I've been choosing everybody. Yeah. 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 Okay.
Hello there, thanks very much. My question, I think, probably is maybe talking about what might happen at another conference that you might focus on next year. Pretty much all of you have talked about emotional health in some way, purpose, hope, joy. And I wonder if we could go into more depth about what that actually means. Because they're all kind of very general terms. We've got into quite a lot of depth about various supplements and ketones and various other things, but more detail and exploration around what actually does emotional fluency mean? What do these things mean, and how could we become better at it? Because these are all learnt skills, and I'd be interested to on your views of how we could better examine ourselves and understand more about our emotional health.
It's quite hard in Britain to really stand up and go, let's all, throw our caution to the wind and talk about our emotional health. But I think there's a movement generally to being more emotionally vulnerable and opening up and expressing our feelings. And I think for me, that's the shift. It's having communities where you can, without shame, talk about your concerns, your problems, your micro traumas that have all aggregated over time, without, like I say, without having that shame attached. So for me, emotional health is, being able to work with not just a therapist, but also as part of a community, as part of a friendship group, and to really just open up and embrace that feeling of allowing yourself to be vulnerable and sharing. But of course, there's the caveats that many of us carry the burdens of past traumas that may be more significant that need formal psychological support. And I think we haven't touched upon psychedelics, but I will just put my flag up and say that it's a very interesting area in mental health. And given that my background was in psychiatry, I'm following this research very closely. Psychedelics in for like magical mushrooms, LSD, etc., and all the trials that are going on at Imperial, Harvard, etc., looking at refractory depression and other mental health disorders. So I think if you're interested, I would look at that world as well, not just macrodosing, but microdosing, because I think that is changing the paradigm of mental health and the way we approach it.
I'd like to echo that. I mean, needs to be a lot more research, not only in psychedelics, but I'm also very interested in cannabinoids. And so on, that we all know about. But coming back to the question, what do we define as contentment, as joy, as happiness? From a physiologist perspective, what can we measure? And we've talked about blood pressure, heart rate, and all of these other biomarkers that are associated with well-being. So activities that make us content, and your contentment is obviously different from mine, that lead to long-term biomarkers that reflect a state of well-being. I know that's a very general term, but that's what we can measure. So I think that's important that we consider, are the biomarkers changing in a way over time that reflect well-being, so inflammation and so on. That would be the outcome from a state of contentment. That would lead on to well-being.
Very good.
Wait,
You've got one more question.
Yeah, okay, so I think I know your question. I really want to sort of then zero in, because I think that's what people are looking for. They're looking for us to zero in on something. Inflammation in the short term is actually protective. It's protective, it's regenerative, which is why it is a evolutionary conserved thing. When your subconscious, your unconscious, or your body consciously is in a stressed state, it will turn on inflammation, because that is the default position from which to then do its repair. We know that research on the field, when a football player in the US anyway, so this is back in the US, when a football player is hit in the head and the brain gets, and it needs to turn on inflammation very, very quickly, because that is going to be, it's going to be protective in the short term. It doesn't actually have that capability, and so it will actually send a signal down to the gut, which is the place of your immune system pretty much. It will actually physiologically cause leaky gut or hyperpermeability. It will actually open up those tight junctions so that your immune system can see things that it doesn't normally see. Long chain proteins and sugars and microbes. Turn on, send a signal back up, and then light up the brain with inflammation. Which is why on the field, if you get a head knock, usually within 5 to 60 minutes, you'll have diarrhea. So if you can then take that and realize that inflammation is protective for people who are stressed, they've actually got low-level inflammation constantly. In the short term, protective. In the long term, detrimental. That's why we need to really work on this, however it is that you're going to work on it.
I want to say a word about this from my point of view. I think a particularly important thing is to feel that one is listened to, or has somebody one can speak to who will listen carefully and in an interested way, and not immediately dismiss you with a bit of facile advice, which is not listening to the other person. So the ability to be listened to seems to me to be so important to our good health. My sister says that whenever I speak in public, I forget about the two most important things. So I'm going to try and imagine she's here and I know what she'd want me to say. She said, "You haven't mentioned God or dog once in the day." By dog, of course, she means the importance of a pet. She has a dog, of course. And it is indeed true that people in old age with pets do seem to be, on the basis of my observation, reasonably happy. Also, people who are fortunate enough to have a faith seem to me to be in a better mental state, most of them, than the average. So God and dog ought to go on your list as two things to look for. Find your own God, find your own pet. I think there is evidence of lifestyle things that we can create in our old age that are beneficial. But I wanted to finish by saying you've listened to me on and off for a whole day. I can't tell you how much good you've done to my mental health. Thank you.
Well, on that note, I think it's an opportunity for us to boost the egos of our wonderful speakers one last time. Thank you all very much for offering up your time to all of us in the audience. I hope everyone has come away with some sense of contentment, maybe a little bit less inflammation. Dennis, do you have any final remarks that you'd like to make?
From the...
Yes.
Oh, well, I've got this. Yes, but I somehow need to stand up for final remarks, and I'll be relatively brief. I've just got two. Is that okay? Yes. The first thing to say is that I'm deeply moved by this meeting for two reasons. The first is that I somehow imagined that we would be a meeting of nonagerians. Is that the right word for us, Christopher? Yes, you see, and most of the people here are at least 50 years younger than me. You can do the calculation, you'll see what I mean. That's fantastic. That gives one great hope that there is a move to do something about this. Now, why should we? I commented earlier on that this was, in a sense, an indication that there's a need for a return of the integrative way of thinking. Not that the reductive way of thinking has not been extremely important in science. I'm not an anti-reductionist in that sense at all. We need the reductionist approach, and I've used it in my own research. But we have, I'm afraid, badly neglected precisely what we needed to face the crisis of old age. This is urgent. And the difficulty is that we've now got something like 3 generations of scientists, medical scientists, that have been raised without that kind of teaching, without being introduced to those methods. Many of them, of course, are employed in our laboratories today. And that's a problem. It's like turning a great big battleship around. But somehow we've got to do it, because the crisis that is coming in healthcare as a consequence of the aging populations is beyond what most of us can face in terms of the cost. And certainly our politicians are not facing it. It's huge. And if you doubt that, look at the first of our broadcasts where we had the health economists telling us what the cost really would be. We somehow have to move this battleship around. So I feel very encouraged by this meeting, and a huge thanks to everybody who's contributed to it, and not least to our inspirer, Leslie Kenny. Thank you very much.
And with that, we hope you all go forth to your various communities in New York, Reykjavik, Argentina, wherever from you've come, and share what you've learned today. There are more videos for free from past seminars at the oxfordlongevityproject.org. And that draws us to a conclusion. Have a wonderful evening, everyone.